Today, we're taking a deep dive into a health issue that's incredibly common and can be really serious. Deep vein thrombosis, or DVT.
Hmm.
We're talking about blood clots, most often found in the legs. And diagnosing these quickly, accurately, well, that's a huge challenge in healthcare.
It really is.
Yeah.
DVT isn't just uncomfortable, it's a leading cause of death and disability worldwide.
Wow.
And the diagnostic puzzle is complex. It's not just finding the clots, but also confidently ruling them out in, well, the vast majority who don't have it.
Right.
I mean, for every one person confirmed of DVT, maybe up to 9 more get investigated but turn out not to have it.
9 others. That's a lot of investigation. And that process itself is a major bottleneck, right?
Yeah.
The gold standard, the confirmation, is a compression ultrasound.
Right.
And when skilled specialists like radiographers, radiologists do it, it's highly accurate. The paper we're looking at says, what, 94% sensitivity?
94% sensitivity, 97% specificity. Very good number.
There's a scarcity of these specialists. That's
Yeah.
the problem.
Exactly. And that leads to delays.
And those delays can be critical, can't they?
Absolutely. Guidelines recommend confirmation within just a few hours, or maybe 24 hours if you start interim blood thinners.
That quick.
Yeah. And beyond the clinical urgency, there's a big cost. In the UK, DVT diagnosis costs something like $175 million a year.
Wow.
And a lot of that is spent investigating those cases where DVT is eventually ruled out.
So it seems natural that people are looking towards AI here, exploring how AI tools might help, maybe ease the pressure, speed things up, especially in resource-landed settings.
Exactly. And that's the focus of our deep dive today. We're unpacking a specific research paper published in NEJM AI.
Okay.
It looks at a particular AI-guided ultrasound device developed for detecting DVT.
So our mission then is to really understand what this study found. How did this AI tool actually perform when they tested it? What do the results tell us about its potential, but also, just as importantly, what are its current limitations? Particularly for diagnosing proximal DVT and when used by staff who aren't radiology specialists.
That's the key context.
Okay, let's start by digging a bit deeper into that diagnostic challenge itself.
Right. So just suspecting DVT based on signs like swelling or pain, well, that alone is unreliable.
Not enough.
No. So healthcare pros use predictive tools, things like D-dimer blood tests, clinical scoring systems, to figure out who really needs that definitive imaging, the ultrasound.
Okay.
But that ultrasound itself is still crucial for confirming or excluding the diagnosis.
And again, that standard compression ultrasound done by the trained specialist, that's the benchmark, right? The gold standard.
Yes, that 94% sensitivity, 97% specificity, that reflects the performance of experienced sonographers.
But the issue, as you said, is the time constraint.
Right. It takes time because you need those specific skills, and there just aren't enough people with them available everywhere right when you need them.
I remember reading there were previous efforts to, train other people, nurses or GPs, to do some limited DVT scans.
That's right. The paper mentions studies showing they can actually achieve pretty decent accuracy too, in the low to mid-90s% range.
So 91, 95% maybe?
Yeah, somewhere like 91.7% to 95.8%. But even those approaches, they still required a certain level of specific training, skilled professionals, maybe a different category than radiologists, but still skilled.
So the bottleneck wasn't completely gone.
Not entirely removed, no. Which brings us neatly to the potential solution tested in this study, a device called AutoDVT.
AutoDVT.
Correct. It's essentially AI software paired with a handheld ultrasound device. The specific one in this trial was a Clarius L7 HD, I believe.
And the key idea, the sort of promise here, is how it's meant to be used.
Exactly. It's specifically designed to guide non-radiology specialists. Think, general nurses, maybe doctors not trained in radiology,
Okay.
to perform a focused, limited compression ultrasound. In this study, it was a 2-point scan,
2 points.
looking at the common femoral vein and the popliteal vein, common spots for those proximal DVTs.
So the idea is to make this complex, skilled task accessible to more people with, minimal training.
That's the ambition, yeah. The software uses machine learning as prior development was published. But what's really striking is the training time mentioned in the study for these non-radiology staff.
How long?
About 60 minutes on average.
60 minutes. Compared to years of specialist training, that definitely sounds like it could address the accessibility and speed issues if it works.
If it works.
So how did it actually perform in a real clinical trial?
Okay, so that's what the AID-EVENT study aimed to find out. This was a well-designed study, multi-center across 11 UK hospitals.
11. Yeah.
perspective, double-blind, so neither the participants nor the staff doing the standard ultrasound knew the AI device's result.
And who were the participants? Just adults referred for a DVT scan anyway.
Yes, exactly. People already in that diagnostic pathway. The core method was everyone got an auto-DVT scan first, done by one of the non-radiology trained staff members.
Right.
Then, straight after, they got the standard clinical compression ultrasound done by a specialist. And that specialist scan was the reference standard, the ground truth for comparison.
And critically, you said the auto-DVT result was kept hidden, didn't influence care at all?
Absolutely crucial point.
Yeah.
Totally hidden. It was purely for comparing against that reference standard later. The main goal, the primary endpoint, was to measure the sensitivity of auto-DVT when used by these non-radiology staff.
Sensitivity. Why focus so heavily on that specific measure?
Because with DVT, missing a clot, a false negative, is the most dangerous mistake.
Right.
It could lead to really serious things like the clot getting bigger or breaking off and going to lungs of pulmonary embolism.
Which can be fatal.
Exactly. So the study set a pretty high bar for sensitivity, 90% or higher. They wanted it to be at least as good as the standard of care.
Okay, 90% sensitivity target. Did they look at other things too, like specificity, telling people they don't have it?
Yes, definitely. Specificity was looked at, also positive predictive value, or PTV, how likely a positive result means you actually have DVT, and negative predictive value, NPV, how likely a negative result means you truly don't have it. Plus, they looked at scan times, user-friendliness, any disagreements between auto-DVT and the standard scan.
Okay, let's get to it then. The main results. Auto-DVT used alone. What did they find in that primary analysis group?
So they analyzed data from 294 participants out of 414 enrolled initially. Median age was 64, about half male. And DVT was actually confirmed by the standard ultrasound in about 10.5% of this group.
10% prevalence. Okay. And the key finding, the sensitivity of auto-DVT.
Right. Here's where it gets really interesting. The sensitivity of auto-DVT used by the non-radiology staff was 68%.
68. Wow. That is well below the 90% target they set.
Way below.
And significantly below the 94% you mentioned for standard clinical ultrasound.
It really is. It basically indicates that the device, as used in this specific study setting, missed a substantial number of actual DVT cases.
Okay. What about specificity? How well did it do at ruling out DVT in those who didn't have it?
Specificity was 80%. Now, this did actually meet their preset target, which is 60% or higher.
Okay, so it met the specificity target, but missed badly on sensitivity. What about those predictive values, NPV and PPV?
The negative predictive value, NPV, was 95%. The positive predictive value, PPV, was 28%.
Okay, that MTV of 95%. At first glance, that sounds pretty good, doesn't it? Like, if the device says you're clear, it's 95% likely to be right.
Yeah, and this raises a really important point that the study authors discuss quite carefully. While 95% sounds high, NPV is heavily influenced by how common the condition is, the prevalence.
Which was low here, about 10%.
Exactly. With low prevalence, NPV will naturally look higher, even if the test isn't perfect. The really crucial comparison is against the gold standard. The NPV for the reference standard ultrasound was 99%.
Ah, 99 versus 95.
Right. And that difference, that 4%, might seem small, but in a safety-critical situation like ruling out DVT, it's actually very significant. You need to be extremely confident that a negative result is truly negative.
That's a critical nuance. So yeah, a seemingly high NPV isn't enough on its own if the sensitivity is poor and the gold standard is much better.
Precisely. And this low sensitivity, the 68%, it means the device generated quite a few false negatives, dangerous ones.
How many actual DVTs did auto-DVT miss in the study?
So out of the 31 participants who were confirmed positive by the standard ultrasound, auto-DVT incorrectly diagnosed 10 of them as DVT negative.
10 missed clots out of 31.
Yeah, that's almost a third. And that's why the sensitivity is so low. The authors are very clear. This level of sensitivity is just not acceptable for safe clinical use as a standalone diagnostic tool.
Were these missed clots maybe small ones, or in really tricky places?
Well, the study gives some detail on this, and it's quite concerning, actually. 4 of the 10 missed DVTs were in slightly more distal areas, like the distal popliteal or proximal calf veins, which can be harder to see sometimes.
Okay, understandable, perhaps.
But crucially, 6 of the 10 missed clots were in the larger proximal veins, the common femoral or popliteal veins.
Oh, the main ones they were targeting.
Exactly. These are typically easier to visualize and are considered the most clinically significant DVTs to find because of the higher risk of PE. Missing those is a major issue.
Wow, yeah. Okay. What about the other side of the coin, the false positives? People told they might have a clot when they didn't.
Yeah, that happened too. Auto-DVT incorrectly diagnosed DVT in 53 participants who were actually negative, according to the standard ultrasound.
53 out of how many negatives?
That's about 20% of the true negatives getting a false positive result.
1 in 5.
Yep. The study suggests the AI might have mistaken other things for a clot, like a Baker cyst behind the knee or maybe inflammation of a superficial vein, thrombophlebitis.
So you've got low sensitivity, meaning missed dangerous clots, and a significant number of false positives causing unnecessary worry, follow-up tests, costs.
Yeah, it definitely sounds like it's not ready for prime time as a standalone tool based on just those results.
Correct. That's the clear takeaway from that first part. But the study had a second layer of analysis, which is actually really insightful.
Oh, no. What else did they look at?
They looked at the actual images captured by the auto-DVT device. They had expert clinicians review them afterwards, retrospectively.
Ah, okay. So this is trying to figure out, was the problem the AI's interpretation of the image? Or was it that the non-expert user, even with the guidance, just couldn't capture a good enough image in the first place?
Yes, exactly that. Trying to sort of disentangle image capture quality from the AI's interpretation ability.
Makes sense.
So they had the recorded auto-DVT scans. 5 qualified clinicians independently reviewed them. They assessed the image quality and then made their own diagnosis just based on those images.
And then the diagnosis from one randomly chosen expert reviewer was compared to the original gold standard ultrasound result.
Okay. And when the experts looked at the pictures captured by the non-experts, did the accuracy get better?
It did improve somewhat. So in this remote review analysis, they analyzed 223 participants here. Sensitivity went up from that 68% to 85%.
85%. Okay, that's better. Definitely closer to the target, but still short of 90%.
Still short of 90% and still quite a bit lower than the 94% benchmark for standard USS performed by specialists.
Right. And what happened to specificity in this expert review analysis?
Interestingly, specificity actually dropped a bit, down to 73%.
Huh.
The NKD was 97%, again, slightly improved, but remember that prevalence effect. And the PPV was pretty much the same, 29%.
So even with expert human eyes looking at the images captured by the guided non-experts, it still didn't quite reach the required accuracy threshold.
Correct.
What did the experts say about the quality of the images themselves? Could they even confidently make a diagnosis from these scans?
Well, this is where another really important finding comes in. A significant chunk of the initial scans reviewed by the experts, 24%, almost a quarter, were deemed indeterminate.
Indeterminate, meaning?
Meaning the experts felt they couldn't make a confident diagnosis, positive or negative, from those images at all. The quality just wasn't there.
Wow. A quarter of the images captured by the non-experts using the AI guide couldn't be confidently interpreted even by human experts. That feels very telling.
It does, doesn't it? And because of this, 71 participants actually had to be excluded from this remote review analysis because the randomly assigned expert reviewer happened to call their scan indeterminate.
So it really throws into question the input data, right?
It strongly suggests that a major challenge here isn't just the AI's interpretation algorithm, but the fundamental difficulty the non-radiology trained staff had in consistently capturing images of sufficient diagnostic quality, even with the AI guidance system.
So, yeah, if the input images aren't reliably good enough for expert humans to read, it's maybe less surprising the AI struggled too.
That seems like a very reasonable inference. Although it's worth noting, the remote review did correctly identify DVT in 4 cases that the auto-DVT software alone had missed.
Ah, okay.
Which suggests that maybe both image quality and the AI's interpretation played a role in those initial false negatives. It's complex.
Okay, so pulling this all together, auto-DVT alone wasn't accurate enough. Expert review of the captured images improved things, but still fell short and revealed that many images weren't even interpretable. So what does this study tell us overall about where this technology stands and, maybe more importantly, why it didn't perform as well as hoped?
Well, the main conclusion from the authors is unambiguous. Auto-DVT's test accuracy, as demonstrated in this trial, was not sufficient for safe clinical use when compared to the standard reference method.
Not sufficient, okay. And based on their discussion in the paper, what are the likely reasons for that lower accuracy, especially that problematic sensitivity?
They point to several key factors. One is kind of inherent to the device's approach.
Yeah.
The AI guides a limited 2-point scan, just those 2 spots.
Yeah.
The standard clinical ultrasound, done by a specialist, involves scanning the veins much more extensively, checking along the vessel maybe every 10, 15 centimeters or so.
A much more thorough look.
Exactly. So this more limited view, compared to that comprehensive specialist scan, is a known limitation of simpler two-point compression strategies in general, even when done manually.
Okay, so the AI might be helping find a spot or two spots, but it might inherently miss things because it's not designed to look everywhere the way a skilled human does in a full scan.
That's likely part of it, yes. Another major reason they highlight is simply the challenge of capturing consistently good quality ultrasound images, especially for non-experts.
Which the high indeterminate rate really pointed to.
Precisely. And they also measured something called inter-observer agreement on image quality among the expert reviewers. Basically, did the experts even agree on whether an image was good or bad?
And did they?
The agreement was poor. They reported a weighted kappa statistic of 0.13, which is a very low agreement.
So even the experts looking at the same image couldn't agree if it was good quality. That really underscores the difficulty.
It does. And it brings us back to the point that performing an ultrasound isn't like taking a photo. It's a dynamic, skilled task.
Right.
The study discusses how experienced sonographers rely constantly on real-time feedback that you just can't fully replicate by following dots on a screen.
Like what kind of feedback?
Things like the physical feel of the probe compressing the vein. Does it squish easily or is there resistance? Immediately recognizing when an image looks suboptimal, knowing instinctively how to adjust the probe angle or the pressure or patient positioning to get a clearer view.
That sort of tactile, intuitive skill.
Exactly. That kind of dynamic human-device interaction, that skill honed over time, is incredibly hard for current AI guidance systems to fully replicate or replace.
Ah, I see the distinction now. It's very different from AI looking at, say, a static chest X-ray or a CT scan image.
Totally different.
In those cases, the AI and the human radiologist are essentially looking at the exact same fixed data, the same picture.
Yes.
But with ultrasound, the data itself, the image quality, is generated moment to moment through a skilled human action. The AI's input depends entirely on that action.
That's the key difference the study really brings into focus. The quality of the input image the AI has to work with is directly dependent on the skill and adaptability of the person holding the probe, even when they have guidance.
And we shouldn't forget the false positives either. They also contribute to the device not being ready, right?
Absolutely. While missing a DVT is obviously the primary safety concern, getting a false positive result isn't trivial.
No.
It leads to unnecessary follow-up tests, potentially unnecessary anticoagulation with its own risks, and causes real anxiety and stress for patients.
So despite that initial promise of speed and ease of use, the accuracy just isn't there yet for safe clinical use on its own.
That's the unavoidable conclusion from these findings. But the study is still valuable because it gives us solid insights into why.
Okay. Were there any genuinely positive findings? Any glimmers of potential that came out of the study?
Yes, definitely a few things. One significant positive was the scan speed.
Ah, how fast was it?
The median auto DVT scan time was only about 4 minutes.
4 minutes compared to, what did the study say for a standard clinical scan? 15, 20 minutes?
Yeah, 15 to 20 minutes typically, even for experienced staff. So 4 minutes is a massive potential efficiency gain if the accuracy issues could ever be resolved.
Huge potential for improving workflow, yeah. Anything else on the plus side?
User-friendliness seemed okay. The non-radiology staff who used the device generally gave it positive feedback. It met the study's definition of user-friendly based on a standard questionnaire, the PSSUQ score.
So the people using it found the software itself easy enough to handle.
Guide seems so, yeah.
And how about consistency between different operators? If two different nurses use the device on the same patient, would they get similar results?
They did look at this, although for a limited number of scans, only about 6% of the total, they said. But for those scans where they did assess it, there was good agreement between different non-radiology operators using the device. They reported a kappa statistic of 0.73, which indicates good agreement. So it suggests that if they can manage to get adequate images, the device might provide consistent results between users.
But that's a big if based on the image quality findings.
It is. And the study did note that this analysis of interoperator agreement was incomplete due to staffing issues and availability, which they list as a limitation.
Got it. Any other key strengths or limitations of the study itself we should mention?
Well, strengths definitely include its multi-center nature, which makes the results more generalizable. The double-blind design is strong, reducing bias, And the fact it was done in a real clinical setting with the actual intended users, the non-radiology staff, is important.
Real-world evidence.
Right. Limitations besides the incomplete inter-operator analysis include the fact they only tested it with one specific model of handheld ultrasound device. Results might differ with other hardware.
Okay, so bringing it all together then. What's the path forward suggested by these results? Clearly, it's not ready for rollout now, but what needs to happen next?
The study concludes pretty clearly that the software needs further optimization before it could be considered safe for clinical use by non-radiology staff.
Optimization how?
They really emphasize that improving the ability of the user to capture better quality ultrasound images, even with the AI guidance, is absolutely vital. That seems to be the main bottleneck.
Making the guidance better at helping get good pictures.
Essentially, yes.
Yeah.
Or perhaps changing the training or the workflow. They suggest that iterative refinement, maybe using lots of real-world scans captured by non-experts during training and testing to further train the algorithm and guidance system, could potentially help.
So it feels like the core technology, the AI interpretation, might be part of the issue, but the bigger immediate hurdle is solving that human-machine interaction problem, getting consistently good input data in a dynamic procedure like ultrasound.
That really appears to be the core takeaway from these results, yes. The promise for speed and accessibility is there, but the fundamental challenge of reliably acquiring a high-quality diagnostic image using guided non-experts remains a major hurdle.
So why does this deep dive matter to you, our listener?
Well, because AI is coming into medicine in so many different areas,
Yeah.
right? And this study gives us a really concrete, quite sober look at where the rubber meets the road when you try to apply it to a tricky, dynamic diagnostic procedure.
Yeah.
It shows that the success of AI in healthcare isn't just about building a clever algorithm in a lab. It's intensely about how that AI integrates with the real-world clinical task, with the human operator, and with the inherent messiness and complexity of generating reliable data in the first place.
And it's a good reminder that when we're talking about critical diagnoses like DVT, where mistakes have serious consequences, accuracy and patient safety just have to be the absolute top priority, even when there's a really tantalizing promise of speed or convenience from a new technology.
Couldn't agree more. And what's fascinating here, I think, is how clearly this study reveals the sheer complexity of trying to translate what is currently a highly skilled, dynamic, almost artisanal human task performing a good ultrasound into an AI-guided process for non-experts.
Yeah.
It highlights challenges that are fundamentally different from just applying AI to static images like X-rays. It shows the specific frontiers AI needs to conquer for safe, widespread use in these kinds of hands-on procedures.
That distinction between AI for static versus dynamic imaging really comes through strongly from this study.
It really does. A key insight.
Okay, so let's recap our deep dive then. The auto-DVT device, this AI-guided ultrasound, showed genuine promise in terms of speed, potentially much faster scans and user-friendliness for non-experts in this trial. But its accuracy, especially its ability to correctly identify people with proximal DVT, the sensitivity, wasn't nearly sufficient for safe clinical use when compared head-to-head with the standard ultrasound method performed by specialists.
Yeah, that 68% sensitivity is the headline negative finding.
And a major challenge appears to be improving the consistent capture of high-quality, interpretable images by non-expert users, even when they have the AI guidance helping them.
Exactly. The study provides a clear benchmark of where this tech is currently at, and it really highlights the specific crucial areas, particularly image acquisition, where improvement is needed before it could be safely implemented in clinical practice by non-specialists.
And it leaves us, maybe, with the final thought as AI continues to push deeper into diagnostic medicine. As we chase the undeniable potential benefits of efficiency and accessibility that AI can offer, how do we ensure we rigorously maintain the diagnostic accuracy and absolute patient safety that currently relies so heavily on complex, evolved human skills and judgment? What stands out most to you from this study?